This panel is entitled Prescription San Joaquin Valley, Caring Professionals and Valley Health, and our panel is moderated by Karen Paulinelli. She is the Chief Executive Officer at Madeira Community Hospital, and she's joined on the panel by Joe Neves. He's a Kings County Board of Supervisor, District 1, Nina Cornell Plata, RN, Vice President of Population Health at Adventist Health, Joyce Eden, MSN RN, Director of Clinical Transformation at St. Agnes Medical Center, Valerie Fisher, Deputy Sector Navigator of the Health Workforce Initiative, and I know Valerie is RN as well, and Catherine DeFede, MSN RN, Director of Nursing at our West Hills College, Lemoore. Please join me in welcoming panel 2.
Good afternoon, and I just want to thank Linda again for allowing me to be here and our panelists to be here today. So just a little bit about what we're going to be doing this afternoon is that I'm going to give a quick presentation about Madeira Community Hospital. That's where I work. My name is Karen Paulinelli, and then each of our panelists are going to give a quick presentation. And I just wanted to say that lunch was really amazing, and before we had our lunch, I said, I'm not going to have dessert. And then they brought this amazing dessert to our tables, and I was like, oh my gosh, homemade ice cream. It really is my weakness, and so of course I had to have that amazing dessert, so thank you very much. So I'm going to go ahead and get started with a quick presentation about myself and about Madeira Community Hospital where I work. When Pilar was here earlier, and I know she's not here right now, she did talk about educational highways. And I really wasn't going to talk about my educational highway, but I thought I was intrigued by what she was talking about, and I wanted to share my story really quickly about that. So I walked into Madeira Community Hospital 36 years ago, and I didn't know what I wanted to do when I grew up, to be honest. I was very young, and I walked in there and I asked them if I could get a job there. And at that time, you didn't need to be certified to be a nursing assistant, and they said sure, and they hired me as a nursing assistant. I had no training whatsoever, and I became the nursing assistant there. And quickly, I looked around at all the many healthcare careers, and I said, I think I want to be a ward clerk. And so, because, it was kind of amazing how doctors wrote, and nobody could read their writing, but for some reason, I kind of had a knack at reading their writing. And then I said, what are all those little squiggly lines? I think I want to be a monitor tech. So I took a monitor tech class, and then the hospital we were really fortunate in Madeira that the hospital really help promote education. And they had this LVN program, and they worked with one of the adult schools, and I went through an LVN program at Clovis Adult School. So it's in the Central Valley, and I became an LVN, and then we had a program in Merced, and then I went from there and I became an RN. And I just continued my education, all with the help of Madeira Community Hospital. So I feel very blessed about that. And then I decided, a doctor came up to me one day, and it was Dr. Massey. He's no longer there. He's a family physician. He said, Karen, you're a really good nurse. He goes, have you ever thought about being a nurse practitioner? And I said, I don't even know what a nurse practitioner is. And it was back in 1992, and UC Davis had a program, and Stanford had a program. It was the only 2 programs in California, and I applied and I got in. I was very lucky that I got in, and at that time, UC Davis's program was also a physician assistant program. And if you were an RN, you were able to sit for your physician assistant boards. So I've also board certified as a physician assistant. And it's really helped me in all these years that I've worked at Madeira Community Hospital. And so I'm just saying that, there's so many great stories in the Valley about opportunities and what we're doing there. And so I just wanted to share that little bit of a story with you. So a little bit about Madeira Community Hospital. We're a 106-bed facility. We're an acute care facility, and we're the only acute care facility in Madeira that serves adult patients. And so we're very fortunate. We serve over 60,000 patients, and we have a 10-bed ICU and a 16-bed ER. We're very, very busy, and we also have rural health clinics. And We have 3 rural health clinics. We have 3 on our campus that they're really actually a part of one clinic. One of them is a family practice clinic, and we see over 100 patients a day there. And then we have a specialty clinic, and we have 27 specialties in our specialty clinic. And 3 of those are telemedicine clinics. And we're able to serve, all of the needs of our community. And most of our patients, 70% of them are here locally that we serve, and 70% of them are Medi-Cal. And so we're really happy that we're able to serve that. And I really do have a passion for rural health. And one of the things that I've also really been involved in for some years is the California Rural Health Association. And about 2 years ago in July, they nominated me as the president for the California Association of Rural Health Clinics. So I'm very involved throughout California in rural health and making sure that we do, that we continue to serve the rural health communities in California. So Madeira Hospital supports about 724 jobs, and it generates 33.3 million in labor income, and the average salary of our employees in Madeira Hospital is about $46,000. $46,000 a year annually pay. And in our emergency room, we see over almost 35,000 patients each year, and in our clinics, we see about 60,000 patients. And we average about 3 births each day at Madeira Community Hospital. And some more stuff about Madeira Hospital is that we are accredited by HFAB, and we also, for the last 9 years, received an Excellence Award from Health Grades in our Labor and Delivery Department. And we're really proud to say in fall of 2017, we received our first ever Leapfrog score of an A. And Leapfrog is a safety organization that makes sure that hospitals are providing safe care. And we're very proud that we received our first A score. And I wanted to really tailor my presentation today about what we're doing, because I knew that what we were going to be speaking about today and what this meeting was about. So I just want to talk about some of the things that we're doing at Madeira Hospital. We are very involved with educational partnerships, and we're doing a lot of precepting and training many students in the Valley. And from Clovis Adult School, we train LVN students. Fresno City College, we train RN students. From the California Health Sciences University, we train pharmacy students. California State University, we've trained nurse practitioners in the past, and we train their BSN program students, RNs. Madeira Community College Center, we train LVNs and RNs. And in Merced College, we work with the radiology program and train ultrasound techs. And then recently, Samuel Merritt is coming to Fresno, and they're bringing a physician assistant program to Fresno. And I'm working really closely with them, and we've already signed a contract with them, and we will be precepting some of their physician assistant students as well. And with San Joaquin Valley College, we train in our clinics the MA students, and we are very heavily involved in the high school as well with their CTE program, trying to get young folks to think about healthcare careers early on. Some of the other things that we do at Madeira Community Hospital to support education is that we do give scholarships out, and we've been giving scholarships out for about the last 20 years. And last year, for instance, for high school students, we gave out $11,000. We also give out employee scholarships, and we give anywhere from $500 to $10,000 is available to our employees if they want to advance their careers. And last year, I think we spent about $30,000 on giving to our employees to make sure that they can continue their education and advance in their professions. Some of the advisory committees that I serve on, because I am very passionate about education and promoting health, is I do serve on the Madeira Community College Center Advisory Committee for their nursing program. I'm also on the advisory committee for the CTE program at Madeira Unified School District for the high school. And Fresno Pacific's nurse practitioner program, I serve on their advisory committee, as well as the National University's nurse practitioner program. And more recently, as I mentioned, Samuel Merritt is coming to Fresno. They've already formed an advisory committee, and I'm on that advisory committee as well, because it is really important. We do not right now currently have a physician assistant program in Fresno, so I'm really happy that we can help them create their program. So one of the really things that important things that I want to share with you that I'm very passionate about is, like I said, I'm a nurse practitioner, and Lisa Hood, who's in the audience, if Lisa, you want to raise your hand. Lisa's from Fresno Pacific University, and of course I work at Madeira Community Hospital. We're both nurse practitioners, and we both have a passion to make sure that there's nurse practitioners in our rural areas to serve our community. One of the things that we've dealt with for many years as since we've had our rural health clinic since 1992, and I used to work in our rural health clinics, and I was a director of our rural health clinics, and we always had a really hard time recruiting nurse practitioners. And one of the things that I realized is that many times nurse practitioners graduate from schools and they don't become nurse practitioners. They don't feel comfortable sometimes going out and getting that first job as a nurse practitioner because maybe their clinical education wasn't as good as it could have been. And we don't really have a way that we standardize nurse practitioner training. And so Lisa and I got together and we said, let's change the way that we train our nurse practitioners. Let's do something innovative and new and different that nobody else is doing. And so that's exactly what we did. Back in May of 2017, we started our first cohort, and we got together and we really worked on forming an academic partnership, and we did a pregraduate residency program. So there is lots of residency programs that's after people graduate, but we wanted to do it while they were in the program. And so they come to us and they have a year of their clinical education that they need to get done. And so what we did is developed a program where they start in our family practice clinics and they rotate through all of our specialties in our specialty clinic. And we even included going through radiology and lab, because when you become a nurse practitioner, you not only have to take care of the patients and know what to do for them, you also have to interpret their lab results. You have to know how to prescribe their medicines. You have to know how to read an x-ray. And so we've rotated them through those different areas so that they can learn those things, because they're not often taught in programs, because there's so much to learn in those 2 years that you're training. And then we rotated them as well inside our hospital through our hospitalist program, and also and then in our surgery, so they learned how to suture, and if that wasn't enough, we decided that we need to expand it a little bit more. And everybody was asking questions about what we were doing, and our community doctors got involved, and we were able to expand it to our community doctors. And all of our community doctors, almost all of them in our community, are now having some of our students rotate actually in their specialty care areas as well. And so it's been really a fantastic program. We just started our fourth cohort, so we're really excited about it. We've been tracking a lot of information about what we're doing in this program, and I wanted to say that we are publishing a paper, and it was accepted in the Journal for Nurse Practitioners, and it should be coming out in the next couple of months. And a couple of days ago, Lisa and I found out that we were invited to speak at the annual state conference, because they want to know what we're doing, because it is innovative and it is different. So we're really excited about being able to do that, and that's going to be in February in San Diego. So one of the other things that I really wanted to talk about, because I did see that the collaboration was needed for hospitals to work closer with our behavioral health services. Madeira Hospital, just like all hospitals in California, we really suffer with the overabundance of mental health patients in our emergency rooms. And every day we have 5 to 10 patients sitting in our emergency room waiting for placement. We do not provide psychiatric care because we're not a psychiatric hospital. We're not even allowed to provide psychiatric care, but yet we keep these patients in our ER because they have nowhere to go, and they need somebody to take care of them. And we gladly take care of them, but the resources is not there, and we all know, and I think can acknowledge that the more resources is needed. And so this collaboration, it started really out of my frustrations when I became the CEO. Actually, I was the chief operating officer, and it started a couple of years ago. And it really was my frustrations where, highway patrol, the local police, the jail, people would just come in and they would drop patients off that were behavioral health patients. And many times we couldn't take care of them because physically they were violent or just needed really more assistance than what we could really give. And so, my frustrations, I reached out to all of our community partners and I said, we really need to come together and we need to talk about what we can do to better serve the patients of Madeira, and how do we, help these patients that are reoccurring, coming, day after day or week after week, because it's the same patients that keep coming into our ER. And we developed this collaboration team, and I will say that we involved the local the police, the behavioral health. We have invited children's hospital to our meetings, community hospital to our meetings. We've learned so much about each other, and what I will say today is that when somebody brings a patient in that's a mentally unstable patient that could be potentially a danger to themselves or to us, our police now stay with that patient. They sit with that patient. They make sure that we're safe. They make sure that the patient is stable before they leave, and they just don't walk out the door. So we've really grown and did a lot of really great things. Our behavioral health department is also, helping us to make sure that they're helping us find placements for those patients. But there's so much more that needs to be done. And so, but what I would say is that it has been very much a growing opportunity for our collaboration. And we started out calling ourselves the 5150 Committee, but we changed that name to we really did. It was like, we changed that name very quickly to a community collaboration, and that's what it has left as. And we have invited more and more people here to join us, and we've learned so much about each other. And so no more is there this battle between the community partners. It's now we're a partnership, truly. And so I just want to leave. I'm going to end my presentation saying that more work is definitely needed, but thank you for having me here, and I'm going to pass it on to the next person that's going to do our presentation. And at the end, if there's time, we'll have some questions.
Good afternoon. I also want to thank West Hills College for hosting this event. Very much appreciated. It is after lunch, so if you nod off, I certainly understand, because it happens a lot at our board meetings, and especially during my presentation. So I will fully understand if you nod off. My remarks are more centered around the Fresno Kings Madeira area. I've served on the Behavioral Health Board of Kings County, as well as the Calviva, which is a Medi-Cal managed care facility that handles that region. Through Calviva, we handle about 358,000 souls through about 2,000 providers. Those are primary care, hospitals, labs, pharmacies that try to attempt to provide care to those individuals. Telemedicine, I kind of want to echo everything that's kind of been said here today. I think has a tremendous amount of potential in the future. And whether or not it's through an electronic device, a computer, or however that communication can be accomplished, I think is a very positive role. But it's not just the ability to have broadband in the valley, it's the width of that signal as well. Because the more that you introduce that technology into especially this industry, the more uses they have for it, and the more it gobbles up all the bandwidth. So when you talk with your technicians and your IT people, whatever they say you need, double it, because you're going to need it, or even triple it, because it's just a nature of the beast. Once you get hooked on that technology, you want more. And so make sure that you have an adequate amount of bandwidth to be able to deliver that services. I think one area that has kind of not been touched on much here is a little bit more on the behavioral and the chronic disease prevention. And I think a lot of that can be delivered through those electronic devices, whether it's a Fitbit coach or some other kind of monitoring devices. I think that's going to allow that healthcare professional to have a better understanding of what their patients are doing. And also the preventative side. We really need to get ahead of the curve. There's not enough goals set to encourage prevention and wellness. It's one thing to understand what the issues, and it's very important to deal with treatments and cures, but we also have to deal with prevention and wellness. And that's where our communities are a little bit deficient in their health literacy. The Affordable Care Act certainly introduced insurance and introduced the vehicle, now we have, and medicine is not unlike any other industry. You look at the cars that you drive. You know, the car today, as compared to a car of 10 years ago or 15 years ago or your first car, medicine has almost, gone way past that technology. And so some kind of way we have to increase the health literacy of our community so that they understand wellness. They understand that prevention of a chronic disease, whether that's diabetes, high blood pressure, heart disease, is a much better option than trying to treat it. But every community is unique. Every community has its unique challenges. And that's where it's going to take a dynamic person to be able to identify that. I know I shouldn't have ate all that ice cream, but I did not leave one drop. So it's the ability to know what you need to know, but it's also the ability to develop strategies and be able to allow people to understand, to take more control of their wellness, and whether that's physical or behavioral health. A lot of times someone presents to us in crisis, and we deal with it, but if you can give that patient the tools to be able to deal with that crisis when they feel with it in the future, that's going to hopefully prevent other long-term hospitalizations or care. And whether that's in a group setting or whether that's in a nurse practitioner or physician assistant, we need to invest more in those positions, but we also need more entry-level group participation to try to intercede on some of those patients, especially in the behavioral health side. On the disease management side, just as the video showed, intervention is a lot better. And again, the health literacy of our communities is not very good. So if you can spend some more time with that patient and allow that patient to better understand their health condition and better manage their disease, the better off we're going to be. It's going to take a very skilled individual to accomplish those goals. And I don't think it's going to be a career path. I think it will be a part of a career path or a career highway. I don't think you're going to have a person that's going to have a 40-year career as a Fitbit coach. But I think you can cross-train individuals, and whether they're a physical education coach or some kind of physical therapist or in the medical delivery field, I think if you take that individual and let them try to develop a strategy or a goal in that community, the better off you're going to be, and again, create the ability to establish better health behaviors, make better outcomes. But again, I'm still not going to leave any ice cream on the table, and that's where the problem is. And we spend a lot of money at Calviva as far as cultural competency and linguistics, but I think sometimes we miss the boat because people are going to eat what they're used to eating, and I think we need to enforce more portion control. And we need to understand what they're eating and then boil that down to figure out how much they need to eat, because I come from a Portuguese family. You sit down, you don't eat, you don't get up until the table's clean. You just don't leave anything there. So, and there's never been any portion control built in. And that little thing that's inside you that tells you you're full, mine's broke. It doesn't work. Yeah. So, but some kind of way we need to allow that nurse practitioner, that physician's assistant, that Fitbit coach to be able to instill the importance of that behavior. And don't eat till you can't move, just eat till you need to, till you feel, and not even till you feel satisfied. The old saying, some people eat to live. I live to eat. And so that makes it very difficult, especially in disease management, and especially when the health literacy of many of our communities is just not really up to par. So with that, thank you very much for being here. Thanks again to West Hills College. I am an alumni, and one of these days, Stu, I'll pay the rest of my bill. Still trying to work it off with community service, but I understand. Thank you very much.
Hi, my name is Nina Plata. I work for Adventist Health, and I am the VP of Population Health over the Central Valley Network. I'm working on my 28th year with Adventist Health. I actually started out in Glendale, and I came here 8 years ago, and I was just overwhelmed at what different medicine it is up here. And so I want to tell you a little bit about our network. Number one, we just won the H vote in Tulare County. Yesterday, we celebrated with the staff and the community. So we have 4 hospitals up here. Can you hear me? Oh, sorry about that. Okay, thank you. And in the United States, west of the Mississippi, Adventist Health has the largest rural healthcare network in the United States. So that's amazing. And that's something in Southern California that I did not get a taste of till I came up here. The Central Valley Network serves 4,000 square miles of clinic space and area. We have clinics in Madeira County, we have them in Kern County, so our footprint is huge. We're also members of Adventist Health, and which has 21 hospitals and multiple clinics throughout the whole organization. And we're very, very thankful for Cerner. The one thing that overwhelmed me here at first was, if you look at the Human Development Index score, we're one of the lowest in the country. And so, which is crazy, we're poorer than West Virginia. And some of our scores and some of the people that we serve are in incredible need. So one of the things we measure, for example, Public Health does, Madeira County does, St. Agnes does, is we look at our community health needs assessment. And if you look at all of our community health needs assessments, they're all, the top 4 are all the same, they just might be in different orders. And with the California Hospital Association this year, we joined with many of our sister hospitals to talk about and to really put together a needs assessment that really got a diverse amount of people to respond. And our plan at Adventist Health is to take these monies and instead of saying, hey, here's a squeeze ball at our market night and, things that won't, when you go home, it won't make sense. We want to take those monies and target them towards diabetes and obesity, lung issues like asthma, access to care, because that is a huge problem that we have. I mean, for example, here, when I first started, I took the diabetes program under my wing, under Population Health. We had an 80% no-show rate for people who are going to learn about diabetes. So just as Mr. Nunez says, this is something, and it isn't, there's other things that we're not seeing behind that, meaning they have a job, maybe a child is sick. Transportation is a huge issue here, too. And what we see every single day is substance abuse is an issue in mental health, and our ER is also full. So within our California Central region, which that'll make sense when I finish my speech, we have 11 hospitals. So at the top of that, we have Lodi, we have Sonora, and all the way down to Bakersfield. And each of them kind of have their own demographics that makes them different. And if, for example, Kings County, they don't smoke as much as they do in Sonora. And in Sonora, they have hardly any Spanish speakers, which is just wild. And I can't tell you, we do need Spanish speakers, especially as nurses and educators. So I want to step back because as we were talking about, and I'm going to be a baby boomer retiring in 10 years, okay? So that's really, really what population health is about, because we're going to have to figure out at a certain cost how we're going to care for everyone, because end-of-life care is the most expensive. So if we look at total health care spending in the United States, it's expected to reach $4.8 trillion by 2021, okay? Up from $2.6 trillion in 2010 and $75 billion in 1970. It's huge. So the Institute of Medicine put together what they call the triple aim, okay? That's where they want health care to go. That's our target, okay? It is Healthcare needs to be a great experience for everyone. Well, and that's really hard because each person is so different and has different expectations. It also needs to be low cost. And so that's my job, is I want to look at the whole continuum of care to make sure we're not duplicating services, and it really is what each person needs. And the last is efficient and effective, high-quality care. And we want to nail it. We want to get an A rating, and actually we're almost there. I'm from Selma, we had an A. Anyway, so what we're doing at Adventist Health is we created an accountable care organization, and we're actually working with Cerner right now to create a tool, because what's so hard is when you look at all these lives, how do you put them together? And when I first started my job, I'm like, oh my gosh, I need a lot of quality people that can do metrics. Well, guess what? Cerner has that, and they worked with some of our great competitors in the United States. And they're able to look at and stratify lives to look at the high utilizers and the rising risk utilizers. And we're also currently working with CalViva, and we have 17,000 Medi-Cal lives. So you think, oh, wow, we're going to get to play in this game. Well, these are the people that don't make very much money, so they're impoverished. Their education level is quite low, and they have a lot of family dynamics. I mean, we serve the homeless. So it was, for this, following the high risk was really hard. We actually set up where we have peer educators go out and go to these people's homes and work on social determinants of health and some really, really rough problems that they have. And we healed some, but I would say the majority we didn't. So we decided to take a step right and deal with the rising risk, where we have someone in our ER right now, Monday through Sunday, 7 days a week during the peak hours, working with all of our patients that have been in more than twice a month and have been in more than 4 times a year. And we're really asking them, what can we do for you? And coming down to their level, seeing really what the barriers are. Access to care is huge, because guess what? Do we offer after-hour services? Do we offer 7 days a week services? And some just want to come because guess what? They know our door-to-dock time is great. So we started working with this, and we've actually done very well. And this is with our CalViva patients. And we're scheduling appointments at the gurney side. We're signing them up to the patient portal. And we're having discussions, and maybe the first time we talk to them isn't the time that they're ready, but the next time or the next time we're seeing an increase in portal access, which a lot of people didn't want to do that before. The most important thing, though, is that we are having conversations then with the physicians after, making sure that they understand that their patients are coming in, that they need to reach out to them and see really what's wrong and put the high risk, moderate risk together with maybe, hey, I need to see them more often. Okay, so I'm going to tell you a little bit about what we're doing and I'm sorry, I was gone for a month and I got invited and I sped through my slides and they're not great. Okay, so I told you the why. Okay, so our organization, and we're at the tipping point right now. We have not moved over, so we still want to get all those ER visits. We still want to keep our census up. So there's a lot of difference on how we're doing things because money counts. But we are definitely, and I know that the head of Adventist Health is definitely, we're moving to value-based care away from fee-for-service, okay? And our current state is we're at the tipping point. So I talked about baby boomers. We know the federal deficit is there. Cost of health care, IOM, gaps in care. So that's what my job is, to look and to discover with the physician leaders on where we find the gaps in care. And I'm going to tell you a couple of them. In our ER, we had a patient that had been in 23 times in 1 month. And this person was living in a senior living where there's no support. In other words, you've got a senior living apartment. And she was deteriorating, and she did not have anyone that was helping her like a case manager. And so what we did was we reached out to the doctor. Well, the doctor was a physician that, he was like in his 80s and still practicing. And he did not know how to get her into skilled nursing unless maybe he threw her in our ER. Well, he was on vacation, and he was because we somehow got the note, and he was saying that he felt like she was had dementia and she was deteriorating. And so finally, we got her family, we got her into the pathway for skilled nursing facility without going through a hospital. But this took us a lot of work. It took hours. And so the thing is, too, is if you look at this case management model, that's what we have on our acute side. And that's where we need to go nursing-wise, is we need something outside that puts together on processes on how to get patients to skilled nursing, to have conversations about palliative care and hospice and aging and choices, for example, like the PULSE form. So in the last month, we have created a case management team that will be reaching out to each clinic and trying to connect the high utilizers back to the clinic, but also if they have difficulty with things like skilled nursing, DME, food insecurities, we're going to, at that point, connect them. Okay. So we're now in the value-based care versus fee-for-service game, which I just said, and we have created an accountable care organization. I'm not sure if everyone's familiar with this. This is for Medicare patients, and so what happens is you get a whole bunch of physicians joining, and you get hospitals that join this, and then other different types of care providers. And based on quality scores, you can get quality reimbursement for doing a great job. But, you know, it's based on 3 years, and then you go to at-risk, kind of like readmissions and core measures. So what happens is, after 3 years, you can also be dinged. But every year you can also, let's say you have a physician that is not great at quality scores, you can actually say, oh, we're not inviting you back. Okay, but also the group of physicians, if you have one not performing, they don't get anything, and you put together a scorecard, so the ones that perform great will get the most money. So we're very excited about that, and that's part of MSSP right there. That's Medicare Shared Savings Program. Okay, so what we're doing, and I'll just run through this really quick because I know I'm probably going over, is we're partnering with a lot of community agencies. Mental health has been a great partner for us. We have a brand new behavioral health leader who is absolutely fabulous. CareLink is a whole person grant, and basically CareLink is a case management program for Medi-Cal citizens, so they link them to housing, they link them to Social Security, they link them to anything that they need. Wellness Bridge Project is something very similar, and Wellness Bridge Project actually is working with investors to create homeless housing. So we've just actually, in our first meeting, we housed 4 homeless in one meeting, which was great. King's Partnership Prevention is a coalition. We have 260 members, and this is all the stakeholders in different business sectors within Kings County, and that is where we're going to do a lot of our work. And so we're really excited about that. We have food banks that we're dealing with, so we're actually giving prescriptions to patients that have talked about having food insecurities. And respite beds, so for any of our homeless that, let's say they have abdominal surgery, we're able to put them in a bed till they recover, and some are 3 months. And they don't always agree, though. Okay, and we're dealing with social determinants screening, and that is something big and something that hopefully we can develop into something meaty, and I'd love to have Cerner kind of be the tool that we say, oh, you're in this county, you can do this. So outpatient care management, I told you about that. Telehealth has been huge for us. We are going to be putting together, and actually we just signed a contract for behavioral health, so that we're having that in our ER, because they talked about the 30-day having the pediatric patients. Sometimes ours are there for 14 days at least, and it's very sad. And I think they almost have the same meal every day, because that's what the ER has, an ER meal. In Hanford, we have a community garden. We just got funding to have one in Lemoore. And I talked about food prescriptions. Complex care is a brand new, actually it's a year old. We've been taking our really high-risk patients and having them see 2 doctors. And these doctors have a whole array of educators. So they have a respiratory therapist, they have an RN, a dietitian, a chaplain, and that's actually the one they want to see every time, and a pharmacist. And with the MD, they see the patients either once a week up to once a month, and we've really made some huge changes by taking blood sugars. Or we had a man who was insulin dependent, and I think he was having something like 300 units a day, and he became insulin free after. And it took months, but that's the little goals that you were talking about. And our emergency room utilization. And lastly, we are also working on a brand new framework for Malcolm Baldrige. It's called Communities of Excellence, and we are in a cohort with 6 other cities around the country. And one is Missouri, and they're not doing very well because it's all ag and a lot of the businesses have moved out. But we're with Toledo, Ohio, we're with Florida, we're with West Virginia, and actually San Diego's another city. And we're learning how to take our missions, our visions, and our values and talk to different sectors within our city and come up with goals that together with the community to improve all of our social determinants of health. Okay, so big thing is prevention. We will be hopefully doing care planning in the future with all of our patients from birth to death, and that's including SMART goals, so it will be small and easy to understand. Our goal is that we'll be doing diet, food, and exercise prescriptions in the future. And I think the new healthcare is going to be dietitians, social workers, physical therapists, and coaches. I think the MDs, if they can get everyone healthy or healthier, that's the ones who are going to be doing all the hard work or the hard lift. We're also using churches to partner on a lot of things. I can see them partnering more with especially the aging of America, because a lot of people, like my father just passed away, and my mom's going to need help, and who's going to help but the church? And so Blue Zones is something Adventist Health is looking at, and Blue Zones is written by a author from National Geographic, and what he's looking at is the city, there's cities, I think there's 5 across the world that have the most centurions anywhere, and Loma Linda, California is one of them. There's an island in Japan, there's a Greek city, Italian, and Costa Rican. And what it is they have 9 common things. Exercise is one of them. There's a family's really important, in other words, social. And then one of the recommendations is you should have 5 best friends that you grow old with. Okay? Another is families should be like most important. You should have socialization, exercise, food, and so on. So I recommend it as a read. But right now, that Adventist Health is talking with this organization, trying to bring it to all of the cities that we serve. Iowa is actually trying to be a blue zone themselves, whole state of Iowa. And there's a couple other, I think one of our, Castle Hawaii is also doing it. And end-of-life discussions is where we're actually going this year. And wearables is really important. And so I see the future in that because and I think that iWatch, my husband told me they just gave 40,000 away because they're starting to look at, measuring cardiac, measuring all sorts of things from that. So we feel that's a big future. Okay.
Hi, my name is Joyce Eden, and it's a privilege to be here with you today, and thank you for inviting us to be able to participate. I personally have already learned a lot. So I'm going to share some information with you about St. Agnes Medical Center. So St. Agnes Medical Center actually was founded at the request of a bishop. 8 Holy Cross sisters established it in the downtown Fresno at Fruit and Floridora. If you drive by there now, it's actually Glen Agnes. It's a retirement center. The original 75 beds only required 32 staff. We are now at 436 licensed beds, and we need at least 2,600 staff to make sure that everything required in today's environment is taking place. So after 3 years of operation in the original St. Agnes, they actually got their designation for the American College of Surgeons. And being the Sisters of the Holy Cross, one of the things I've learned in working for this hospital and for Trinity Health, whom we belong to, they are very, very committed to the community, and they have been committed to excellence and quality, and that still stands today. So in 1977, they were the 10th palliative care hospice that opened up in the United States and the 3rd in the state of California. So hooray, California, because if 3 out of the 10 were all there in 1977, that was a big deal for California. So I'll give you a little bit more history before I get onto this one. So as a member of Trinity Health, one of the things that we are provided with is we actually have critical access hospitals, we have large hospitals, we have networks. So we actually have some that have the skilled care, the hospital, and the ambulatory care is all a network in that medical system. And so there's a lot to learn from being part of a larger system, but it is a really interesting position to be that we are their only California one. So we are their thorn in the side in the development of their EMR and EHR strategies, because did we mention we have 4 regulatory agencies in California, not 2. So we always have to push back on them about the design, and at this time we are a Cerner shop as well. So the big data that we have access to, the technology, evidence-based practice, research, making sure that things are standardized and that our physicians are able to compare and use scorecards and see their best practices has been an amazing event for us. So in fiscal year 18, we discharged 24,654 from the hospital. Our ED visits were at 89,000 for that year, and for the last 5 years, our graphs that you can see, the visits to the ED are just on an upslide, as well as our behavioral health volume. So it's been constantly growing for the last 5 years with no dips, and sounds like from the data shared this morning, no dips in sight. So for this slide, we are very fortunate to be a baby-friendly hospital. This means that we actually have a lactation clinic. It's outside of the hospital to make it easy for the moms to get to us. We actually will coordinate a home visit. If the moms need that, we'll go out to them. But the whole premise here is that the healthier we can get that baby, the healthier adult it will be someday. So this really promotes breastfeeding, and we actually have set up a system where breast milk can actually be donated now. It's actually treated in the same whole process as a drug management, where it's labeled and everything is handled very carefully for making sure on the expiration dates. But that's part of how you get to be a baby-friendly designation. We have long-standing partnership with Valley Children's, so as many of my other colleagues have shared, we have a high volume of patients who have low income and low literacy. So we actually partnered with Valley Children's, and we have a floor of antepartum high risk, and they actually have a satellite unit in St. Agnes for a full-blown NICU. And so most of our helicopter visits to St. Agnes now are actually these high-risk moms that are being brought into us from all over the Central Valley. So we're very fortunate to be able to provide that. And then we, I think, have been well known for our heart program. The history around that was really interesting to me when I joined St. Agnes. The original heart program was actually opened by Valley Children's in the Central Valley, and they did adults and pediatrics, but when the adult volume started to grow, they actually ended up moving that to St. Agnes, and nurses are still with us who were part of the original staff that opened up the first adult heart program here in the Valley. So we are very fortunate to be recognized for the cardiac care. And then in expanding our facilities, we have an imaging and emergency department expansion. When the emergency department was built a few years back in the early 2000s, the new department was already too small. It was designed for about 45,000 patients, and upon opening, we were at 60,000, and I'd already mentioned to you that we're at 89,000 now. So on many given days, if you come in, we've gotten really innovative and creative with our Lean Six Sigma work on how we use every inch and how we do the flow, and actually have been able to keep our offload times and our care delivery at a pretty good state. But it does require that we remodel. So for those of you who would want to be aware, what does that mean? It means that we're just in the design phase right now, and then we have to get clearance for our through OSHPD and make sure that we're ready to go. So from design to build, we're looking at 2 to 4 years, depending on how that will all get phased out. But we're looking forward to a new plant someday. So we are known for our Catholic belief systems, and that's community outreach. Our mission in motion is there's a St. Agnes Holy Cross Center for the Women downtown. If you're familiar with the Poverello House rescue mission, that they partnered, and they're all down around in the same area, so that there's a special place though for women and children to go. And on any given night, there are several women, up to 120 to 200 of them at night, that have a safe place to sleep at night and a place for their children. So the other thing I wanted to mention is we were able through a grant to open a community outreach called the Hub. So when we get patients in the hospital or in the emergency department, that as we assess them, our social workers or case managers recognize they're either homeless or very underserved, the Hub actually hires community workers. So as we've talked about where do we need to go in the future and we need to take the care out, when you go to a person's home, and sometimes that's on the street corner, that's where they tell you they live and that's where they choose to live. So wherever they say they live, that's where our community worker goes and meets with them to see that part of town they live in, even if it's on the street, because our whole goal is to try and help them still get doctor's appointments, still get their medications filled, and if we need to pick up the meds and deliver them to them because that's where they choose to live, then we try to do the best we can to get them to a better state of wellness and to help them manage their health. This Holy Cross Clinic downtown, a nurse practitioner is the primary provider here. All of the other care is volunteered by physicians, dentists, respiratory therapists, nurses, anybody who has an interest in coming and serving. This is open Monday through Friday and 1 to 5 in the afternoon, but we saw 7,900 medical visits last year and 600 dental visits. So, and this is completely free of charge. It is completely funded by foundation donations and by the staff who volunteer their time. So in the world of expanding resources in the Valley, we have our first cohort of residents. We started with internal medicine. That team is just currently coming up, and then last week we received word that we will be able to start our first cohort of family practice residents next July, so those interviews will start shortly. But you heard again, statistically, we do not have enough providers for the patient and volume of per capita that we have here in the Central Valley. So I do want to tag on a little more around the nurse practitioners and PAs. The PAs are able to work at full scope because they're functioning under a physician. The nurse practitioners in California, we're one of the few states left where the nurse practitioners are not able to work at full scope, and I am happy to announce that we actually are partnering on trying to do a third attempt at getting full scope. We came within 2 votes on the last bill, but legislative health is where we have to tackle that, because it's just a crying shame that we have nurse practitioners and many who want to work in the underserved areas and they're not able to do that at full scope. So along with growing residents, because research says if I complete my program in this area, I'm more likely to stay here, because usually through their residency they've married, had kids, made relationships, and so that's been part of the strategy of St. Agnes in starting the residency program. On any given day, though, we have the nurse residency program, and we run 2 to 3 cohorts a year for bringing in new grad nurses through that program. And we are a sea of color. So if you come to St. Agnes, you'll see blue, green, red, but we have students from every nursing program, from the pharmacy program now, from respiratory, from the LVN. So we know that if we don't support clinically people getting their training, that's not going to fill the needs here in the Valley. But I would like to again reinforce things that were said this morning. We know that we have to find different clinical sites. And with the population health management, with the ACA, we are pushing care out of the hospital, which means we've got to train nurses and any clinicians and even community workers in the setting in which those patients are going to receive the majority of their care. The other thing that we were blessed to do was to actually create our own surgical tech training program. So we've had a chance to supply some of those. And then what happens is that after we train them, they do go other places. So you're welcome. We're happy to share. So in expanding access to primary care, we are again a state where you cannot hire physicians directly, but we've gotten creative because we found with California healthcare laws that you can have a foundation. So we were very fortunate last year that we hit our critical mass of having enough primary care sites, enough internist, family practice, actually some OB, and then we have 2 urgent cares that we were able to open. So through the St. Agnes Foundation is how we're trying to do better partnerships and really make sure that we're meeting the needs of the community. And we are expanding our specialty care. We recently were able to bring on neurosurgery. We are reinstituting bariatric surgery effective last week. So there's more expansion going on around that. And if you have questions about that, let me know. I want to honor time and make sure there's time for questions. So I would just highlight that getting care out into the community and trying to get it to the right place. We do now have 2 urgent cares, one out near the 99 in Herndon, and then one that is right in front of St. Agnes. And then we will be expanding and opening some additional clinic site actually out near Clovis community. There will be a children's and a St. Agnes combo because of the OB pediatric care that we have. So for the follow-up care that needs to be done when patients are discharged from the hospital, we're trying to go closer to where they are so that they can get to us. And then we believe in fun. So we can't do what we do without the partnerships from the community. We're very grateful for many, many of them. And we do have quite a few rehab programs. We have a rehab for pulmonary as well as cardiac. And those are very low cost and actually will graduate the costs for those if people can't afford to have them because we want them to stay as well as they can. So we look forward to continuing to serve the community and we're open to any ideas you might have around how we can partner better with training folks or even delivering care afterwards.
All right, we've been talking a lot about some of the wonderful services that are available here in the community. And we're going to switch gears a little bit. My name is Valerie Fisher, and I work for the California Community Colleges. And I'm what's called as a deputy sector navigator, and I work for the Health Workforce Initiative. And basically that's translated into I'm a regional technical assistance provider to the colleges within the region. And I focus exclusively on student success, building new programs for nursing and allied health exclusively. So I'm kind of like your go-to person for that area. So I'm going to share with you a little bit more about the California Community Colleges in general, and then break it down to a real specific in regards to what's going on right here in the Central Valley. There we go. Okay, about 6 years ago, the California Community Colleges decided to retool themselves, and specifically the Economic and Workforce Development Division decided it was time to kind of look at how we were spending taxpayer dollars and how could we make things a little bit more effective. So each region in the state each part of the state was broken up by region. And the Central Valley region is one of the largest ones, as you can see on this map. And each region then also selected, it's one of those tricky ones. I wondered where the rest of the slide was. Okay, there we go. And it's turning, wow, who knew? Okay, didn't do that on my computer. That's kind of cool. All right, so anyway, the Central Valley is one of the largest geographical regions, and we are called the Central Mother Lode region, and we serve from Stockton to Bakersfield, and then over on the east side of the Sierras over there close to Nevada. So it's a huge landmass, and there are quite a few colleges within that region. But each area had to pick out what their primary economic drivers were. So for the Central Valley, what's our primary economic driver? Ag. What's related to ag? Advanced manufacturing or processing and global trade, and then healthcare is number 3. So those are the 3 primary economic drivers, where the jobs are, where the money comes into, and what motivates and keeps us all going. So with that, kind of a strategy, there was an overlay of doing what matters for jobs in the economy, and there's 4 prongs to each one of those areas. So the first thing we had to do is look at our programs and go, okay, what do we need to give priority to? What are the labor market needs? What is the regional inventory? And sorry, Jeff's not here, but community colleges have been doing regional inventories of their health programs for years and years and years. And what are the needs of the employers within that region? So that's how we're giving priority to those specific areas. Then we had to make room. What are we doing that's not working that we need to eliminate to make room for new programs and new opportunities? How can we revitalize the partnerships on our advisory boards and working with industry in general? How can we revise our curriculum and add aspects to our curriculum that is missing, that employers are telling us that's missing? For example, soft skills. You've probably heard that term. It's a very general term, but especially our younger generation folks who've grown up with technology don't really have soft skills. They have a hard time keeping eye contact with someone. Well, do you want someone to take care of you in a hospital if they can't have eye contact with you? I don't think so. So we're having to teach them that. The other thing is innovate what matters. So how can we better serve the employers? How can we innovate and capitalize and form public-private partnerships and develop leveraged funding programs so that we can have more of a collaborative effort in the community? What can we do to serve incumbent workers and deliver specialized trainings? And we are working on some specialized nursing trainings that will come out probably after the first of the year. And the last part of it is, how do we promote student success? How do we adopt common metrics and data points for measuring our success? And how's that data collection happening? And I'm happy to tell you that that's been a long haul, but we've actually put together a common data set, and everybody's on the same page. All the 114 community colleges in the state are on the same page for collecting the same data for student outcomes. Okay, and then how are we going to empower those regions to, with additional resources to make the changes that they need to do in order to serve employers and have students succeed? And that is called strong workforce funding. And I'll talk a little bit more about that in a little bit. Okay, the Health Workforce Initiative is, again, a statewide organization that is under the Division of the Economic and Workforce Development and is part of the Strong Workforce Program and the doing what matters for jobs in the economy. We've been around actually for a long time, but we got refreshed about 5 years ago as well. There are 10 of me throughout the state, so there's 9 other deputy sector navigators that serve their specific regions as well. My expertise is just here in the Central Valley. And what are the kinds of things that we do? We can do outreach, we can do education and training, we do a lot of collaboration and partnerships, and student success, of course, is our primary goal for nursing and allied health programs. Again, the Central Mother Lode region is huge. There are 14 community colleges within that district, from Stockton to Bakersfield, and then east over onto the east side of the Sierras, where there's a Sierra Coso College over there. Here are the lists of the colleges within the region, and you will see that we have a lot. That's a lot for that big of a region, I think. So guess which one on the list is our 113th community college? Nope. Clovis Community College is the newest, is the 113th community college. 114th, I believe, is Compton College, finally got reinstated. So there's 114 colleges now. So what kind of programs are we offering at these community colleges? Well, I rated them by the total number of programs. So for EMT, we have 10 programs. It's a low-paying job, but it keeps young men in particular interested in education. And, you know, they have the opportunity to then go out and work for ambulance companies and get some exposure to trauma and emergency rooms and stuff. And they oftentimes either move on to something else, saying that they're not cut out for that sort of thing, or they come back to community college and pursue another degree. And we also have, as you can see, all the different other programs, anything from LVN to RN Bridge to radiology to licensed vocational nursing, paramedic, psychiatric tech. We have them all. It's amazing. Oops, I did the wrong button again. There we go. And so we keep on coming down. We have healthcare interpreter now, 2 programs throughout the Central Valley. One's in Spanish and one's in Hmong. So if you're an employer here in the area and you're having problems talking to your patients, you might want to think about hiring a healthcare interpreter to help you out. There are only 1 programs in the Central Valley for the following things: physical therapy assistant, speech language pathology assistant, dental assistant, and diagnostic medical sonography, which is your ultrasound. And currently under development is an occupational therapy assistant program, which is going to be at Clovis Community College again. So for a total, from Stockton to Bakersfield, we have over 104 individual programs. That's really good. And the other good news is that when I first started in this role 7 years ago, we had 62 programs. So we are growing, we are trying to meet the need that the employers have, and we're trying to get the students out as fast as we can. And I think that's something to really be proud of, that we've been able to add that many new programs. Okay, about a year or so ago, I developed a new resource for the region. And it's actually a little booklet, and it's all about health career pathways. You know, we talked about the highway earlier today, about getting on a career pathway or a career ladder, or what we're calling them now is guided pathways. Okay, so this book is an all-in-one resource for anyone who's interested in health careers. There's 15 chapters. These are all the major occupations outlined in the book, and then within each one of these is anywhere from 6 to 20 programs that start from a certificate that go up to the doctorate level. So for anyone that's interested in, for example, respiratory care, it has the whole career ladder right there for someone to see. So here's an example of how the book is. This is the first page on every chapter that shows them that for a certificate course, what you can do, and then how you can work your way up all the way to a doctorate degree with 6 years of college or more. This visual is really important for high school students because they really don't grasp and understand how hard it is to get your education and work your way up this ladder. But giving it to them in pieces so that they can work their way up and come into the highway, get on the education highway, and jump off, works great. That's how I did it. Started at the bottom, worked my way up. Then also in the book, I thought, you know what, I originally developed it for high school students, but we found that they're not really the users of the book. To date, we've printed over 10,000 copies. They've been distributed throughout the whole state of California. I was notified yesterday that we are going to go into a 3rd edition printing of the booklet. And the biggest users of the booklet are, who do you think? Who counsels people about jobs and high school counselors, community college counselors. I'm now working with the workforce investment boards and educating their job developers. Everyone needed a resource where all that information was compiled right in one little section. And the great thing is that this information is compiled for the Central Valley. And even though the book has gone statewide, if you look at the salary range, I just tell everybody, if you're out of the Central Valley, just add more money to it. You're going to make more than that. So it was an easy way to do it. So anyway, I just want to thank you for inviting me here today. And if you have any specific questions about developing new programs or what we have to do to go through that at the community college system, just let me know. I'm here to help. I'm here to partner. I'm here to get more people in and out of education so we can get them into the workforce. Thank you.
So my name is Catherine DeFady, and I am the Director of Health Careers for Lemoore College and the Director of Nursing. And first of all, I want to thank Linda, and I want to thank Stu for having this event here. Being in healthcare and doing health careers in the community college system, it's often like, well, you don't understand. This is happening and this is happening. And, you know, they're always listening to us, but we are a very needy group and we don't always fit in the community college system perfectly because we have a lot of special needs and special circumstances. So I really appreciate the opportunity to have everybody here together and you can hear all of what's happening and we can share these ideas, and thank you for doing that. I know that's hard work, so we appreciate it very much. Am I the only one that knows about Pixley? I know you do, Costa. Okay. Yeah. So Pixley, I grew up in Tulare and in Porterville, so I'm from the Central Valley. So, you know, I knew all about Harris Ranch. People are so surprised that it's here. And then I made a big leap to Cal State Bakersfield for nursing school on probation. So I'm very familiar with the Central Valley, so coming back, being here and seeing students do so well and come back and work in this great environment, it's important now to tell you, as we talked about today, some of the good things that are happening. We have excellent collaboration in our Central Valley. We do have some unique challenges in relationship to what we have available and how we're spread out, but I want to thank all of my academic service partners who are here today, both academic and service, we get together once a month, we collaborate, we talk about our issues. I really believe that we can come up with plans and innovative ideas without having to be regulated or told this is what's going to happen, because I think we can solve those issues before we even get there. And some of those are clinical placement issues, but the collaboration that we have here is really a benefit to our area because it's not happening in some of the other areas of the state. So we're really fortunate. Is that right? Nope, that's the pointer. Okay, got it. These are just a brief snapshot of the programs we have within our district here. Of course, we have the nursing program in Lemoore. We have also our EMT certification program. We have a newly initial KHEP accredited paramedic program. So we're watching that community paramedic pilot very closely. We're very interested in that. We also think paramedics make excellent PAs down the road. I'd like to look at pathways for that in the future. Certified nurse assistant programs on both campuses, both Kalinga and Lemoore. Kalinga has also the psychiatric technician program. A lot of those students as well will graduate and come into our nursing program, and many of them want to be psychiatric nurse practitioners. So we like to encourage that. It's an excellent blend to have. Joyce Glaspie is actually a graduate of our nursing program and now teaches in the psych tech program at Kalinga. We have high school pathways. Some are more developed than others, but those are things we're consistently working on. And our North District Center in Firebaugh is also working on health career certification along with our rural health partners in Madeira doing some things in Mendota. So we're very fortunate to have all this support. Our associate degree nursing program also has a concurrent enrollment program currently with University of Phoenix where students can concurrently enroll with them towards their bachelor's degree, so they will graduate with that with less than a year. So the push for us in associate degree nursing programs is that concurrent enrollment. That is where things are headed. So we have a mantra to be looking at our curriculum, looking at our units, how are we delivering this education for our students so they can concurrently enroll, so they can take advantage of as much education as possible while they go through the nursing program. I think we've beaten this dead horse of supply and demand. There's a nursing shortage, right? I don't think I need to talk about that any longer. It is, however, that is the newest data that came out with this recent report, is that even though we know there's a nursing shortage, it is specific to our Central Valley, specific to us. So the BRN is going to be saying no to probably new nursing programs in Southern and Northern California because of clinical congestion, because of no demand. However, it doesn't mean they won't say no to those coming here in the Central Valley, which means we have more clinical congestion now with our partners, and how are we going to manage that? But yet we need to meet the demand at the same time. So these are just, again, some more numbers on that whole demand issue. So preparation of nurses, one of the opportunities that we have had here at Lemoore is we are going through a curriculum revision, a major curriculum revision, which isn't taking your courses and just changing a few things. We went all the way back to our vision, our mission, our philosophy. What do we want our nursing graduates to look like? What is really the future of healthcare, and where do our students need to be able to make that demand? Health Impact contacted us, invited us to participate with the Kaiser Foundation as well as the California Endowment. We were chosen we were one of 4 schools that were asked to participate in this project to receive funding to revise curriculum. And it's to be looking at a changing curriculum that is fluid and that can move with healthcare. This is not something we want to do, is revise curriculum every couple years to this extent. We want this to be a very fluid curriculum that can move with the changes, keep up with technology, keep up with what is happening in our environments and where we live and what is needed for our patients. So we're looking at a total theme of a culture of health for our new nursing program curriculum. We're looking to prepare nurses to just exactly with the things that we talked about today. We're moving out into the community. We are still going to have placements in acute care, but it needs to be very purposeful, specific placements. It has to be very specific objectives of what we're trying to do. I think the way that we probably deliver a lot of our nursing education in the clinical setting is a bit just kind of the way we've always done it. And we kind of wait around for these activities to come along and experiences to come along, and we need to really look at the way that we deliver that and the way that we structure that for our students so they're getting the most out of those hours that they're there. But then, boom, we need to go out into the community. They need to follow up with those patients they've discharged. We need to get in with Calviva Health and make those home visits. I want my students in the homes where they're probably going to be practicing in 5 years or later, okay? So those are the things that we're doing now. Our clinical experiences are called immersions. They are immersions of experiences. Mental health, that's been a very big topic that tends to be a huge issue in clinical placement. Tons of congestion. Our senior nursing student knows very well. We have had them running hither and yon this semester, getting oriented at numerous facilities so they can get a well-rounded experience in mental health. We were offered an opportunity, hey, we want your students to come and have experiences at our hospitals. We have some placements, come and take advantage of that. You don't say no when somebody calls and offers you a space. You take it, but the students have had to pay a little price for that. They've had to work extra. They've had to arrange their work schedules to accommodate all that, and they've been very gracious, and we really appreciate it, but we know that's going to be to their benefit in the future. But where is mental health? And we've talked about it's everywhere. So, we need to look at how we get the students to have those experiences in a more appropriate fashion so they can deal with folks in those areas where they need to. The new curriculum is a major reduction in units in the nursing coursework. So with that being said, the role and the goal is that once you practice here, you can practice anywhere. Once you go through our program, you can practice anywhere. probably somewhere between, I think we've got it down to like 38.5 units. So the goal would be they have a 9-unit semester course of courses with us. They can currently enroll with a university for another 3 units and start working on their bachelor's degree throughout their entire program. So these will be pathways that will be coming. They're being piloted already in Southern California, and they will be coming to us very soon. So we need to be in position to do these things, get our nurses as quickly bachelor's prepared so they can move on to that practitioner role, which many of them are interested in doing, so we can help fill these gaps. But that's the role of the community college currently at this time, is to really make our curriculum where it needs to be and to move on to the next step. Okay, so I was told 5 slides, all right? That's what I did. So I'm done. So Linda, you can get back on and do what you need to do. Thank you.
So we'll go ahead and open up to the audience, and if you have any questions, feel free to ask any of our panelists.
For the booklet, are you interested in getting those out to local hospitals? Because I know Cui Delta might be interested in that, because they do an event every year with the local high schools called Doc Band. I don't know if you're familiar with it, but they give opportunities to students to meet with doctors and nurses and have dinner and ask questions and stuff like that. Just a thought.
The book is really quite extensive and pretty expensive to publish, and it's your tax dollars and mine that's actually paying for it. We would love to share that in an electronic copy, and you can download it off of the HWI website, and that would be CA for California HWI.org. So ca-hwi.org. And you can download it right onto your desktop, and that way you can also figure out which pages you want to print out. If you're focusing on nursing, for example, you can just print out the nursing section. It would be too expensive for you to go ahead and print up a whole bunch of books for those kinds of things. And I still have to saturate the entire state with all the counselors before we can start getting it into the schools, although I will share with you that Fresno Unified School District and LA Unified School District have both bought large lots of the books and have implemented them into their curriculum for their health career explorations.
So anybody else have any questions? I do want to mention one thing that I forgot to mention in my presentation just very quickly, because one of the things that we really are working on in Madeira with Mendota and in Fireball is developing 2 rural health clinics, one in Mendota and one in Fireball. And I did want to mention that because we are in the area that's the rural area here in where West Hills is located, and we wanted you to know that we are going to be servicing that community. Hopefully in the next year, we're hoping to break ground in March, and we're working with the Amor Foundation in the Mendota area. Do you have a question?
So given some of the challenges that you all mentioned in terms of people in the behavioral health space that are coming into your systems, and some of the challenges of care coordination and integration, right? But also recognizing that our mental health system is really county-driven. Mm-hmm. So you've got 3 counties in this region. It sounds like 3 counties in the room. What opportunities do you see for the state to help facilitate or guide a conversation around collaboration, either with our department, with the community colleges, with the Department of Healthcare Services, OSHPED, some of these other departments, that could help you take better advantage of the resources that you do have in ways that makes better use of dollars, personnel? And this is really about leveraging public and private, right? For whoever's got
so
the right answer.
Our clinic systems are quite large, and we feel like the family practitioners, they're the ones who really do the bottom line assessment with the patients. And they see patients before they escalate, and when they're young, and when they might show signs or symptoms. And we do the screening. And I think that they're reluctant to medicate, to treat patients. And for example, our ER, our number one complaint is anxiety. So it's not, schizophrenia, it's something simple. And so I think that if we could teach our providers how to do the basic treatment, because a lot, I think, have fear behind that, that's where we should start. And then we could do that all as California.
And I'm going to add that it's really needs to be a continuum of care, and that I would challenge us all that we need to go upstream, and that we need to get into the homes, and we need to help whomever those caregivers are, because the family unit looks very different today. Grandparents are raising grandchildren and great-grandchildren. So I think we have to start there in helping people learn coping skills, life skills, communication skills. So I have an opportunity to serve with the children's movement in the Central Valley with legislative health work I participate in. So I think we have to look at it multi-pronged, and we have to team up like was facilitated today, that we have to get different people in the same room and be made aware of what the resources are. And my learning through my legislative health has been, I've had to learn what is the state, what is the county, what is the city, what is the medical center, and then what are the other resources. And faith-based has been mentioned several times. I think that especially around behavioral health, family units, support to individuals, I think that many people are willing. It's how do you team up to make it happen? And that I would just be really excited to see something similar where we brought people from all those different levels into the same room to address the behavioral health.
And also, I can address how we're trying to build health career pipelines for mental health. A lot of colleges, that was an old slide deck, it didn't have my inventory for human services / behavioral mental health. A lot of colleges have recently taken on new programs, and I've also worked with several colleges that wanted to develop new programs like the community health worker. And we've had our advisory community meetings from the Fresno area come to public health, came to the meeting and said, you know what, don't train them because we don't have the resources to hire them. So there's no need. I can't document labor market need that there's actually a need that employers will hire this type of a person. The other problem is in that particular pathway, there is a huge gap between an associate degree person and needing a master's degree to actually become a counselor or a family counselor. And there's not very much in between at the baccalaureate level. So we really need to look at what can we train with not a million years of college, and how can we train lower skilled people that still make a living wage, say with an associate degree, and be able to utilize those folks in our community.
The other interesting thing that's cropped up in looking at where should we be in the community, there is not a high presence of nurses in skilled cares, in group homes, again, settings where because there's nowhere else to house behavioral health and the families can't manage it. So there are people who've made an effort, and there are these settings where folks are, but again, I think there's great opportunity in partnering with public health and partnering. Many hospitals are interested in expanding and actually having outreach programs from the hospital, because if you're not aware of it, it's a potential fine to have somebody return to the hospital within 30 days of discharge. So many hospitals are getting creative and innovative as well in how do we partner and do community outreach to where we can make that happen. Some of the really sad cases I see in the emergency department, I had a 16-year-old again the other day where the group homes just had it and they refused to take him back. And so here again, I have that. Fortunately, I had mentioned the hub when I did my presentation. So we started working with them as well as the social work with many resources in the county about where are we going to put that teenager who's not going to be an easy placement if the group home's already not taking them. But part of that's around funding. So that's the other thing is that if people really can't care for themselves, then how do you create the right funding that the group home or wherever we place them is able to manage them and is then got the right resources? Because some of those individuals do require a 2-to-1 or a 1-to-1 monitoring so that they can stay out of a hospital.
Thank you. Well, I really want to thank our panelists, and if we can give them a hand. I know people want to go on break, and we ran out of time. Thank you, guys.